All right, we'll get started now. Thanks everyone for joining us today. For those who don't know my name, I'm Meg Cunningham. I'm the Director of Marketing and Communications here for VNA. And I'm just going to go over a few housekeeping things before we start with our presentation this morning. First thing is I am going to ask that everyone remain on mute. That way everyone can hear our presenters and hear all the great information they have to share with you today. If you have a question during one of the presenters' time, I'm going to ask that you actually put it in the chat. We will be doing a Q&A at the end of the presentation. We have some questions already that were submitted. We're going to talk about those. And then, of course, anything else that might have come up during this time. Also, this is the first of a series of webinars that we're going to be doing over the next few months. And we really want to be able to talk more about our hospice program and educate everyone on the incredible work that's done here. So if you are interested in learning more about our program, I encourage you to like us on Facebook, follow us on Instagram, or you can sign up to receive our e-newsletter on our website. So for now, I am going to hand it over to my colleague, Jessica, who will get us started.
Good morning, everyone. My name is Jessica Nettles, and I'm the Community Outreach Liaison for the VNA. And I want to welcome everyone for joining us this morning, or thank everyone for joining us this morning. Like Meg previously said, the purpose of these educational series is, to help our community get a better understanding of hospice support and services. During this webinar today, you will learn the history of VNA Hospice of Indian River County, how one meets criteria for hospice, what are the signs that it may be time for hospice, who pays for hospice care, and lastly, you will get to meet a few of our hospice team members. So first, I'm going to start off with a little bit of history of VNA Hospice of Indian River County. So VNA Hospice received its hospice license in 1986 and today serves roughly about 160 to 170 patients daily, wherever our patients call home. That could be their private residence, assisted living facility, a nursing home, a senior independent living community. Last year alone, VNA Hospice served 1,619 patients and families. At VNA Hospice, we believe that every person deserves to be treated with compassion, dignity, and respect. And we put that belief into action through a holistic approach, including medical, emotional, and spiritual support to ensure our patients are living the highest quality of life possible. VNA also has a hospice house that opened its doors in the year 2000, which is located right next door to Cleveland Clinic Indian River Hospital. This is a place that our patients can go for end of life care and symptom management when acute symptoms cannot be managed at home. Our hospice house has 12 private bedrooms with private bathrooms, and each room has a screened in porch. VNA also offers respite care at the hospice house for our patients whose loved ones need a break. Caregivers can drop their loved ones off at the hospice house for a 5-day stay. Our hospice house also has a private chef who cooks meals for our patients, their families, and our staff. A lot of thought went into making sure that our hospice house has a home like feel for our patients and their families. So now you're going to hear from a couple of our hospice team members, starting with Kathy Orton, who is our VP of Hospice, and she is also our Chief Regulatory Officer. Kathy, take it away.
Thank you, Jessica. Good morning, everyone. Hospice care provides terminally ill patients and their loved ones support and time together when the focus of care turns from curative treatment to comfort. When you or a loved one is diagnosed with a terminal illness, every moment is important. Knowing your loved one's wishes and making yours known, will create the best end-of-life experience possible. Too often, patients and families wait until the last days to reach out to hospice. Hospice benefit was meant for the patient and their families for not days, weeks, but really months. The benefit extends to 6 months or more as long as the patient has a life-limiting illness. Too often I hear, I wish we called hospice sooner. So please know your loved one's wishes, make yours known, and have that conversation. VNA Hospice Advanced Care Planning Team can reach out to you and provide education and counseling if you need help having the conversation and making your wishes known. Thanks. Okay. When is it time to consider hospice? Hospice care is available to all patients within the county with a diagnosis of a terminal or life-limiting illness and who feel it is time to forgo aggressive care for comfort care. Timely identification of hospice eligibility allows the patients and families to focus on quality of life at the end of life. It is time to call hospice. You can ask you or your loved one certain questions. Is the patient facing a life-limiting disease or condition? Has there been a decline? You know your loved one best, and you can identify physical signs or behaviors that maybe indicate of an overall decline. Have you taken into account the patient's wishes? If you identify any overall decline or change in behavior in your loved one, it may be time to reach out to your physician or hospice to see if hospice would be appropriate for you and your family. Who is eligible for hospice care? Hospice is not giving up hope or care. It is a type of medical care for those patients that have been diagnosed with a life-limited illness, and they have decided that comfort care aligns more with their goals than curative care. For VNA Hospice of Indian River County, you need to live within our service area, which is Indian River County, and certainly consent to accept the care that we provide. Again, it is not giving up hope, but patients have decided that curative treatment is no longer an option for them, and they will receive the medical care that provides comfort care. The hospice team is specially trained in end-of-life care, which can be provided wherever the patient calls home. In addition to pain and symptom management, our team provides an integrative approach for care. Many of our hospice patients live longer than they would have if they continued aggressive treatment till the end of life. Okay.
Thank you so much for that, Kathy. That was some great information. Next, we're going to hear from Dr. Michael Venazio. He is our VNA Hospice Medical Director. And Dr. Venazio is going to speak on his role as our medical director and also speak a little bit about what made him go into hospice care.
Hi, I'm Dr. Venazio. I'm the medical director. I've been with hospice approximately 20 years. I am board certified in internal medicine, and I have a subspecialty as a hospice medical director. I help the team with the care of the patients enrolled in hospice. So I oversee their care along with their personal physicians, and all the nurses and CNAs and everybody else involved in their care, the chaplains and music therapy. So we develop plans to help care for those patients and make sure that they receive comfort and are well taken care of. I got into hospice approximately, like I said, 20 years ago, and went into hospice because my family had a bad experience in hospice with my grandfather, and I had to kind of take over his care when I was in New Jersey and bring him to a hospital where I could care for him and make him comfortable. I didn't want other families to have to go through that. So we strive to make sure that patients are taken care of and families are taken care of, because it's not only about the person that's suffering from a life-limiting illness, but it's also about the families who have to care for them and are involved in their care. I try and visit everybody who is to hospice in the first few weeks of their admission, whether they are in or elsewhere. I also do what's called the face-to-face evaluations of everyone to ensure that they are still within their last 6 months of life if their disease is as expected, which is a requirement of Medicare. And that's generally my role in hospice. I enjoy it, and it's a passion of mine.
Thank you, Dr. Venazio. Next, we're going to hear from Caitlin Kennedy, RN Hospice Case Manager. She's going to speak on her role as our VNA Hospice Case Manager.
Good morning, everyone. I'm Caitlin Kennedy, Hospice RN Case Manager for Indian River County Hospice. I got into nursing because I wanted to make a difference. I got into hospice nursing because I believe the end of life deserves as much beauty, care, and respect as the beginning. As a hospice case manager, my job is to provide support to the patient as well as the family. Every visit, we're assessing the patient's pain, vital sign changes, and any nausea or shortness of breath. If we observe any of these, we're treating the immediate concern and educating the family and patient along the way. Education to the family is just as important as it is for the patient, because this is their story as well. People can be scared about the unknown, and it's our job as nurses to help them along this new journey and prepare both the family and the patient on what's to come. We collaborate with Dr. Venazio regarding our findings, and we begin treatment plans based on his recommendations and expertise. During our visits, we're inspecting to make sure a patient has adequate medications in the home and refilling them as needed. We also provide instructions, whether it be written, verbal, or both, so the patient understands fully why they're taking a medication and what we hope to accomplish with it. During our continued visits, we make sure our medication adjustments have been effective, and we keep Dr. Venazio apprised of our findings. We also provide wound care, catheter changes, and other interventions to maintain comfort for our patients. The nice thing about a case manager is you have a registered nurse overseeing your plan of care and adjusting as needed. You get a set team of nurses, home health aides, a music therapist, chaplain, and counselor who work together to make your plan of care as effective as possible and maintain the continuity of care. Having a familiar face during this journey helps to put patients and families at ease. I want to share with you all a personal story of my own. In 2021, both my mother and sister were admitted to hospice. As a hospice nurse, I figured if anyone understood the process and had it in the bag, it was me. To say I was wrong would be an understatement. When it's your family member, there's a difference. No matter your training or education, it's just different. Hospice of Indian River County walked my family and I through exactly what was happening and made sure we were all well supported and prepared. There will never be enough words to express the gratitude I have to Dr. Venazio and the VNA hospice team for allowing me to be a daughter and sister during that time. The burden of being a caregiver was removed, and I was allowed to be a family member once again. My mother passed very peacefully at home with us at her bedside. Sorry, I apologize. And my sister passed painlessly at the hospice house with us present. Both experiences have left a lasting impression on me, and I understand better my role as a hospice nurse. Each department, music therapy, nursing, chaplain, counselor, home health aides, volunteers, and Dr. Venazio became family, and they helped us to grieve along the way. Our family has continued to receive bereavement support even 5 months after our losses. This continued support has been conducive to our healing. End of life, or the transition phase, as we call it in hospice, doesn't have to be scary. In fact, sometimes it can be a truly beautiful experience. We put my mom and sister on hospice early, and I attribute their peaceful passing to the education, preparation, and continuity of care they received along the way. Hospice isn't about adding days to your life, but instead adding life to your days. And for that, I'm eternally grateful.
Thank you so much, Caitlin, for sharing that personal story with us. Next, you're going to hear from Jacqueline Ruiz. She is one of our hospice counselors.
Good morning, everyone. I'm Jacqueline, hospice counselor. The hospice counselor is an integral member of the hospice team, collaborating and providing skilled medical social services and counseling support to patients and families in the community, facilities, and the hospice house. I will be using counselor and social worker, the terms interchangeably, but they're one and the same. End-of-life care can be an overwhelming, confusing, and emotional time. Often conversations on caring for and supporting a dying loved one have not been openly addressed. Social workers are trained at making these conversations easier, focusing on strengthening communication amongst family members, guiding patients and loved ones through this difficult time. Actively, empathically, and reflectively listening to patients and their families are key functions of the counselor's role, as this helps formulate the patient's plan of care. Engaging and involving patients and families in their care allows them to feel heard, understood, and valued. Counselors identify patient and family needs and goals, educate and provide guidance on available community resources to ease caregiver burdens and strain, and facilitate linkages or referrals to these resources if appropriate. Counselors intervene during moments of crisis, conferencing and collaborating with other team members to problem solve, lighten psychological burdens, while continuing to provide quality, compassionate care. End-of-life planning can be full of mixed emotions, shocking, overwhelming, cumbersome. Counselors assist patients and families with understanding and ultimately working towards acceptance of one's prognosis, address unresolved issues such as establishment of advance directives, final arrangements, or even complex interpersonal relationships, and improve their overall quality of life while coping and adapting to challenges, for example, loss of independence or cognitive decline. The social worker plays an active role as part of the interdisciplinary team, advocating for patients and families, providing insight on significant changes or dynamics, and providing input on patient and family needs. Counselors prepare loved ones for the declining process and educate on the death and dying process. Counselors continually assess for anticipatory grief needs, intervening by providing supportive counseling, educational materials, or initiating referrals to the bereavement department. Bereavement counselors provide emotional support to patients and families throughout and following a patient's time on hospice. We experience grief because of the deep love and connection we have to someone who has passed. Everyone grieves differently. There is no right or wrong way to grieve. Bereavement counselors facilitate healthy grieving by encouraging verbalization of feelings, providing education regarding the grief process, identifying healthy coping skills, and providing opportunities for memorial or remembrance activities. Bereavement counselors can also assist in identifying additional sources of emotional or psychological support in the community. The bereavement department offers individual counseling and various support group meetings for anyone in the community who has suffered the loss of a loved one.
Thank you so much, Jackie, for helping us understand your role as a hospice counselor. Next, we're going to hear from Grace Jones, music therapist.
Hi, I'm Grace. I'm one of our music therapists at the VNA. Music therapy, in short, is provided by a board-certified music therapist, and we use music as a tool to achieve the patient and family's goals. And with music, we can address emotional, spiritual, physical needs. Something that actually makes the VNA unique is that not every hospice does offer music therapy, and so this is one way that we can provide extra and unique support for our patients. So music is really effective with pain and nausea control, with providing music as a positive distraction, and it does decrease the perception of the patient's discomfort. We provide and teach coping skills to reduce anxiety and shortness of breath, to give the family tools to use recorded music when we're not there to keep addressing and coping with the anxiety and shortness of breath. And as we all probably know, music does elicit strong emotions, which can lead to healthy emotional expression and helps process the emotions that the family and patients are experiencing during this unique time. And the sooner a patient or family elects hospice, the more opportunity we have to do advanced interventions, such as legacy work and heartbeat recordings, which we'll hear some examples of. In the first recording, this was a grandfather who was struggling with knowing he wasn't going to be able to watch his grandchildren grow up and be there for them. And so the music therapists that worked with him, they rewrote Twinkle, Twinkle, Little Star for messages for each of his grandchildren with his grandfatherly advice. And we're not hearing the recording yet. I'm not sure if it's.
We'll try again. Hold on.
You're so smart, you could be president. I adore the things you do. You bring me joy and happiness too. I can't wait to look down and see all the amazing things you'll be. To my little Mason, I wish for you great success. I know you will do many great things. I believe you can overcome anything, though obstacles may be in your way. God will not lead you astray. I'll be watching over both of you, making sure you stay in line too. I'll be with you every night and day. I'll hear every word you will say. I wish that I could be there for you. I want you to know I always love you.
Thanks, Meg. Should have given you guys a warning to get the tissue box. Sorry about that. This next recording is another intervention we have the opportunity of doing. We have a device that's looks like a stethoscope, and it can actually record the heartbeats of our patients, and we can use that recording to then play a preferred song and record that over top of it. So we'll play a short clip of that. That's good, thank you. It was a little bit faint, but you get the idea that we can use those as, even if the patient isn't verbal at that point, we can still use something from them to create that memento that they can hold on to, that recording of leaving their legacy for their family. Even with these advanced interventions, music therapy can also be as simple as listening to music that's most meaningful for the patient's life. There are so many therapeutic benefits to hearing the music that we love, and then bringing back those positive memories. Reminiscing greatly improves the quality of life for our patients and families.
Thank you, Grace. We truly appreciate everything that our music therapists do for our patients and their families. And thank you so much for sharing that legacy project with us. Next, we're going to talk about our volunteer services. Unfortunately, Sarah Bumgardner, our volunteer manager, had a scheduling conflict today, but Kathy Orton is going to touch on some of the programs that we have that fall under volunteer services.
Thank you, Jessica. Our volunteers in our program is an important piece of hospice. We have over 450 volunteers working with patients in their home or whatever setting they happen to be in, as well as volunteers in the back office helping to support our hospice program. In hospice, our volunteers are actually considered part of the team and work closely with the team to align the patient's goals and carry out that plan of care. Our hospice program has many programs within it that help support the patients and their families in their home. We have a We Honor Veterans program, which identifies veterans that come into our care and really adjusts that plan individualized to their experiences that they may have had while they were serving our country. Our staff are educated on unique interventions and care for this special group of patients. We also honor our veterans through a pinning ceremony where the team gets together and makes a visit to the patients wherever they are and just honor them for their service and provide them with a plaque thanking them for their service to our country. Our Project Wish program is a unique program that was started based on conversation our team had. Just if we asked a patient, what would be a great day for you? And based on that, we try to make those days happen. We've honored many wishes over the last couple of years. This program is supported by our foundation and our community. Simple wishes like a day at the beach or a picnic with family, to bigger wishes, going out of state to visit a loved son that couldn't make the trip to see his dad. So we try to honor wishes, and that is one question we ask our patients and their families. What would make a great day, or what is something you would really like to do at this time? Our legacy program, our volunteers through on-site visits create similar to what Grace was showing you, although not at that level, but helping the patient journal their life and share that with their family as a keepsake. Hospice volunteers do make socialization visits, respite visits to the home. They provide supportive presence and additional support to our patients and their families. Our volunteers work weekly, making tuck-in calls to our patients, a welcome call to know we're thinking of them and to identify if there's anything else we can do for them. They call each of our patients weekly or more as needed. So this is just a close work with our other team members. Sarah has also developed an agency-wide volunteer program through the American Corps Senior RSVP program. This volunteer program actually encompasses our whole community, and where volunteers can provide social support and services to patients outside the hospice and our home health benefit. as part of that program, we have GrandPads, which is a simple, I guess, for lack of a better word, iPad, specially designed for seniors, made secure. And the seniors can reach out to families, call families, share pictures, play games, whatever they want to do on that pad. So it's theirs and it's tailored to their needs. So just know our volunteers are special to our program, and there are a lot of them, and we always are looking for more to recruit and train. So many of our volunteers are family members of patients that received hospice services and want to give back to our program. So if you're out there and you're a volunteer, thank you. Okay, Meg.
Thank you, everyone. I really appreciate everyone who took the time to write in some questions when they registered. So I'm going to start with those. And to our speakers, you are welcome to unmute and just kind of jump in if you'd like. One of the first questions we had was, what is the monthly cost for hospice care in the home?
I'll start that, Meg. Typically, hospice care is covered by Medicare and Medicaid. So if you are at an age where you're a Medicare or Medicaid recipient, there will be no cost for those services that come under the hospice benefit. Keep in mind, hospice cares for the patient's terminal illness and any treatments needed for that. So we pay for equipment, supplies, medications that are related to the terminal illness. So the hospice benefit does not have an out-of-pocket expense. If you have treatments unrelated to the terminal illness and or medications, that would fall under your other insurance or your traditional Medicare benefit. Most insurances do cover hospice, but if you do have private insurance, it's something that you or we can help you look into. But please know that financial concerns or constraints should never be a barrier to hospice care. We're here to provide hospice care to all who qualify regardless of ability to pay.
Thanks, Kathy. And then someone wanted to know what the average length of time a person ends up usually has on hospice.
Well, I know Dr. Venazio had mentioned that the hospice benefit is it was designed for patients in the last 6 months of life. And that's the best projection a physician can make if the disease runs its normal course. Many patients stay on hospice longer. So most of our patients unfortunately don't maximize the hospice benefit. Our average length of stay can be anywhere from 30 to 45 days. So that's why we encourage everyone to know your patients or loved ones' wishes and understand when it's time to call hospice. So the benefit, again, was meant to be at least for the last 6 months of life.
And then someone asked, can family members at a distance visit virtually? How does VNA support that? And is it part of our care?
It is part of our care. And to be honest, we actually expanded that during the pandemic, understanding that, being isolated or lonely certainly did impact end of life. So we do have the capability in our hospice house and at home and facilities to provide virtual visits. Sometimes we do this through the GrandPad I mentioned. Sometimes we simply do it by FaceTiming. The hospice house does have other capabilities, but we do integrate virtual care, virtual visits. Sometimes we're just low tech. I think Caitlin probably has done this. Just call a patient's family member out of town, put the phone on speaker and allow the family member to have a conversation or offer comforting words to their loved one that they can't visit, because we all know that patients usually continue to hear. So we can be high tech or low tech, but we do support the family that's out of state. are out of area or just cannot make the visit.
Absolutely, especially during COVID, that changed a lot. Families couldn't really travel. So we changed kind of our tactic and made sure that they were able to say their goodbyes and do anything we could to support them.
Okay, great. Someone also wanted to learn a little bit more about the myths of hospice. And I think I'll start with this one because when I'm out in the community and, you know, talking to the public about our hospice program, I feel like I get some of the same questions sometimes, or misconceptions is maybe the better way to put it. And a lot of it, I always feel like people assume is that hospice is for the last days of life. And I know we've kind of touched on this, but I think that's something I know I see a lot. And as Kathy mentioned, the hospice benefit is intended for the last 6 months of life. And so it really is important for our community to really understand how hospice can really help improve their quality of life with their loved ones during that time. And I know another one I've received is, can a patient's physician be involved in the care too? So I'm going to open that up to our speakers to answer that question and also talk about any of the common myths you might have heard.
So I
Meg,
agree.
one of the myths that I commonly hear is that hospice is going to stop all of your medications and then just medicate you with morphine until you die. So we don't stop any medications unless the patient wants the medication stopped. They can't take the medication any longer. You know, we do have a formulary, so there are some medications that are covered and not covered, where people can pay for medications themselves or through Part D if it's not related to their disease. But we don't stop anyone's medications, and we don't come in and just give them excessive amounts of morphine to make them pass. That's all just a myth. The patient's physicians are always welcome to participate in their care. That's an option that's available to everybody. Many of the patients' physicians defer to me because I've been doing it, but they are always welcome to participate in their care.
I can add on to that. We, on our devices, we do send orders to Dr. Venazio, but a lot of times there's a secondary physician that's listed. So it just keeps them, you know, apprised of what's going on with their patient, because maybe they've had them for 30 years and they want to defer to Dr. Venazio, but they also want to follow their case as they transition. So we'll include them in the orders so that they can see an update on their end and know what's happening with their patients.
Thank you for that. Any other myths that maybe some of you have seen, or any common misconceptions anyone has heard?
I've heard a myth that if you're on hospice, you can't ever come off. We do actually have some people that sometimes graduate or change their mind and do want to seek aggressive treatment. And we talk to them about their options. We go over everything. We're very thorough so that they know that if they do eventually things don't work out, hospice is still here for them when that time comes. But we support them if they change their mind and do want to seek aggressive treatment. Sometimes patients do, or the family wants them to. So we're there for them regardless.
Meg, a question. Do cancer patients continue to receive cancer treatment, chemo and so forth, or does that disqualify them for being on hospice service?
Cancer patients don't continue chemo and other treatments on hospice. Those are considered aggressive treatments. So we would not continue those. The only exception to that is if someone has a supply of pills that they were taking and they want to continue them until they run out, they're allowed to do that, but we don't refill it because once you're electing for comfort measures, chemotherapy is considered an aggressive treatment.
Okay, so that's one of the meds that people wonder about in this mythology. I understand.
And also one of the other myths that I hear is you can't go live at the hospice house when you're getting admitted to hospice. That the hospice house is not for people to go to live at for their last 6 months or 8 months or whatever time that is.
Thank you for that. The medication was actually a really good point because we had a question that said, why are some prescriptions covered and some are not? So can we just distinguish that a little bit more?
So the hospice benefit was meant to provide care related to the patient's terminal prognosis. So the terminal diagnosis and any other diagnosis is related to that. So if you have medications that you're taking based on your terminal prognosis, hospice is responsible for those medications. If you take other medications that are unrelated, then that is covered by traditional Medicare or your insurance. So hospice is responsible for any care and treatment related to the diagnosis that brings you to hospice.
Okay, great. And then we had a couple of questions about pain management. I know we've talked about medications. How do we assess our patient's pain? How do we address that? We touched on it, but maybe we can just go a little further with that.
Meg, I want to piggyback on Kathy a little bit. Just an example for people out there is if you come on with lung cancer and you're on high blood pressure medication, a high blood pressure medication would not be something we cover. But also, let's say you come on with emphysema and you're on certain inhalers, they may not be on our formulary and we may not cover them. The patient can still take it, but Medicare doesn't cover them. The patient is supposed to pay out of pocket for those medications. As far as pain goes, everybody's individual and they get assessed for their pain based on their case. So there's no set formulary for how you address pain in anybody when you're trying to control their symptoms towards end of life or even prior to that. Some people may need short-acting medications. Some people may need long-acting and short-acting medications. There's different modalities that you may use. So there's not one set formula for giving pain treatment to anybody.
Okay.
So I know from the nursing side, what we do is we typically during a visit, we're assessing, and of course, pain is whatever the patient says it is. So if it's an 8, my job is to notify Dr. Venazio, hey, his pain's an 8, or the action we chose before isn't working appropriately. Do you want to increase? Do you want to adjust? Do you want to change altogether? And then for someone who's nonverbal or unable to express to us, we look for nonverbal cues. We use what's called a FLAC scale, which is facial grimacing. It's, legs are drawn up, if they have a frown, so there's ways that we can tell if someone is in pain, even if they can't verbalize it to us. So those are all things that we look for during our visits. And again, we will set another visit. Let's say they're scheduled only twice a week. Well, typically what I will do is I will put a visit on in 2 to 3 days just to assess, to make sure that that was an appropriate change and see what we need to do next.
So a follow-on question. As a former paramedic, I'm pretty familiar with pain management administration. I'm under the impression that an RN is required to actually administer pain med. It begs the question, is an RN present at home with our hospice patients 24/7, once a day, once every 3 days? How does that work?
An RN is not required to be present to give pain medications.
Okay.
Most of the people at home are on oral medications, and any family member or the patient themselves can give it. If it's an IV medication, we don't normally do just IV pushes at home because that's not feasible to have a nurse there all the time to do that. We do IV pumps at home where we set the rate and we adjust the rate as we need to. But families are able to give boluses as they need to for those patients.
Okay.
Just like you would if you had a pain pump at home.
Terrific.
So the answer to your question is no, an RN is not always available at the homes or the facilities to give the medications.
Yeah, I wouldn't have guessed so. Thank you.
Thanks, Bill. We did have a question in the chat about if the hospice house is open for tours.
The hospice house is open for tours. We encourage anyone who would like to visit the hospice house to do so, but we also ask you to call ahead just to make sure that the hospice house manager, Stephanie, or someone is available and can set some time aside to take you to see the hospice house.
Okay, great. Those were our questions in the chat and who wrote in. Does anyone have any final questions for our team here? If so, you can unmute yourself and ask. Give it just a couple minutes.
I hope we answered everyone's questions, Meg.
I think so. That was a great conversation at the end there. And I think that really showcases the importance of constantly having these education opportunities available. So we did record this session. We will make it available on our YouTube page. So if you want to go back and listen to something again, we will have that ready for you in the upcoming weeks here. I'd also just want to say again, this is going to be our first session. We have a few others coming up over the next few months. We really want to be able to show people what our hospice program looks like and the real depth that it provides. So please remember, follow us on Facebook, follow us on Instagram. You sign up for our e-newsletter on our website. If you have any questions about what we discussed here today, you can reach out to me personally. My name is Meg Cunningham, and my email is mcunningham@vnatc.com. So I'd like to just thank all our speakers today. You all gave me your morning, and so I appreciate that. And for everyone else who tuned in, thank you so much for your time.